Support for Carolina Business Review provided by Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health is a not-for-profit group of hospitals and medical clinics caring for surrounding communities. Their nurses, physicians, and staff are nationally recognized for their remarkable devotion to patient care. And by Sonoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries.
Well, it wasn't that long ago when hospitals, docks, and just about all things healthcare used to be thought of as a fairly bulletproof industry when it came to the economy. Their toughest part was managing the growth. Well, now, between Obamacare, the Great Recession, pending Medicare cuts in 2012, and more uninsured seeking care, it takes deft, finesse, industry insight, and even some luck to sustain margins. Hello, I'm Chris William, and welcome again. Thanks for supporting the most widely watched program on Carolina business and public policy. As always, we wade right into the healthcare debate with a panel of regional experts and executives, and we begin in just a moment.
Major funding also by the Duke Endowment, a private foundation in Charlotte, enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina, who's responsible for rising healthcare costs. Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. This edition of Carolina Business Review was recorded January 6, 2012. On this week's program, Rich D'Alberto of Lawrence County Healthcare System, David Dunlap of Roper St. Francis Healthcare, Russell Guerin of Carolina's Healthcare Systems, and Dr. Samuel Harris of Women's Center of Lexington. Now, Chris William.
Hello, welcome again to our program. Thank you for joining us, and particularly David Dunlap. David, you're way down there. I say way down there because we're up in the middle of the two states, but you're down there in Monk's Corner, and thanks for joining us, David, because I know you cannot see us, but you can hear us, which I don't know if that's better, or bad, or good, but nonetheless, David, thanks for joining us from Santee Cooper down there.
Thank you, Chris. A pleasure to be with you today.
Sam, welcome. Rich, good to see you. Russ, nice to see you again, and thanks for joining us. You know, let's start fairly broadly here. You can't go to a cocktail party or you can't go to any function, business or personal, without talking, or at least if there is a debate about health care, it tends to get pretty polarizing and pretty passionate is probably a good way to say it. Russ, let's start with you. What do you think is most misunderstood about where we are, the current state of health care?
I doubt many people realize that about 20% of healthcare dollars are spent on 1% of the population. About 70% of the dollars are spent on 20% of the population. So in general, I think it's not very well understood that the majority of people in the United States are paying for the minority of people. So I think that's just a not very well understood concept.
David, statistically, is that something that sticks out in your head, or what might be something that you think, you know, we're way off? We're not even talking about X here.
Oh, absolutely. It's managing those patients with chronic conditions or multiple chronic conditions that is consuming the majority of the health care. But back to your original question, what is it that is perhaps most misunderstood? For most of us, health care is a very personal relationship between ourselves and our physician, or ourselves and our hospital. I think people don't realize the complexities of this vast health care industry, the largest employer in the nation, the largest, one of the largest, first or second largest in the United States. And the complexities of dealing with all the reimbursement issues, the specialists, the primary care, the post-acute, the outpatient versus the inpatient, and I think the more we can work with patients to help them understand their own responsibility, their own personal responsibility for maintaining their health, preventive or making sure they're following their medications, it's going to help them avoid some of those chronic conditions that Russ Guerin referenced earlier.
Is this a personal responsibility? You think that's the biggest part that's misunderstood here? Sam, Rich, either one?
Well, I think we it's a very complicated system, and in my view, things should be made as simple as possible. And people don't understand, like Dave said, that it's a very complex system because you've got so many different things coming to the system. You've got technology, you've got insurance, you've got Medicaid, Medicare, and all they're not coordinated very well. And even the insurance policies, one's so much different from the other. And it's very confusing, and pre-certification, things that we have to deal with every day in doctors' offices that have just complicated and made our staffs larger without really making our care better. And that's a big problem.
Rich, I want to take what just Sam said. You know, from the simple law of cause and effect, doesn't it make sense that if this gets more complex, it's going to be harder to sustain any kind of profitability, and it's going to be harder to deliver any kind of quality care without some type of thesaurus or calculus that you have to have. Is it going to get harder before it gets easier?
Yeah, I think it is. I think you hit the nail on the head. It's that we've got a system that we put together, I believe, piecemeal over the last 75 years, and you know, I like to believe form follows function, and for some reason, you know, it's the other way around in healthcare because of all these parameters that we've been talking about. But go back to the question about the expectation of the public and taking responsibility for their own care. I think I've heard this before. I didn't make this statement up, but I think it is important that, you know, the general public, they want the best health care that they can get, and they want somebody else to pay for it. And our system has created that environment. And I think when you look at the complexities, the most misunderstood thing about health care is that nobody in the general public understands the payment system and what their responsibility is for.
Do you understand the payment system?
I try.
But to your point, it's still a challenge.
It's a challenge because I believe that over the years, we have designed our healthcare system around the payment, around the reimbursement.
David, do you agree with that? Is that how it's set up?
And actually, I think Rich is right on point. I think we're paid to provide health care services for patients, and I think that is exactly what we do. Every system is designed to get the outcome that it's incentivized to do. And I think where the future is we see it, as I see it, is that we're going to be incentivized to maintain a healthy population. In other words, to be able to keep patients in the least cost-effective, the most cost-effective, the least intensive environment that we can. So, but it's going to be a transition. Right now, as Rich pointed out, we're paid to provide services, and that's exactly what we do. And we have a public that is where that's the expectation, is that either through Medicare or through their employer, or even if they're uninsured, their expectation is that someone else is going to be picking up the tab for them. And I want to come back. You know, we were talking before the program and made a point about this personal connection that people have, and I do want to get back to that. But since we're on this, Russ, is there a sense? Does there seem to be a dynamic in the business that to the point of patient outcomes and transactional? How do we go from the transaction? How do we go from just the doc, you know, seeing everything is kind of siloed, the doc visit, the docs, Sam, you're supposed to share information with the other doc or the other healthcare providers. How do we go from a transaction-oriented to a patient outcome? That's what drives us. That's what incents us.
Well, I think there's a lot of ways the Carolina's healthcare system is working on that today. We call it integration, and if you think about it, it's horizontal integration. It is integrating that patient process from the time they go to their physician's office or an urgent care or maybe the emergency room to wherever they end up. And there's handoffs along the way. And in the past, those handoffs have been primarily with different organizations or different practices, and certainly different information systems and different lab systems. And what we're doing today at Carolina's healthcare system is putting all of those together. So there's one personal patient record. And so no matter where that patient ends up, you know, who's ever seen the individual can treat them like an individual. They know what lab work they had 6 months ago, or they know who the pediatrician is. And so that's, we try and develop a seamless kind of encounter for that patient. That's not reimbursement related. That is patient care related.
Sam, I want to say your first line defense on this. You're the one on the ground doing that.
Right. Well, I was going to, Russ hit the nail on the head in some aspects. Physicians, because of the reimbursement, have to become more efficient. And some of that is not duplicating services, which Russ is talking about, because so that one physician knows, carries through from the emergency room to the physician's office to the labs. And that's a very important aspect. We tend to do too many tests that have already been done.
Are you doing that in a defensive result?
Some of it's lack of information, which maybe when we get more better ways of communicating with health records, it will help that. But we get referred patients all the time, and it's not something we can wait on, and we can't get the information to find out. The patient is not sure what was done, and so sometimes it's easier. It's not more efficient, but it's easier to repeat the test to know what's happening.
Sam, is that policy, or is that a factor of technology why those records aren't shared more easily?
Well, it's technology right now. I think it's getting better, but it's back in the quote old days. It might be a week or two before you got something. If something was 50 miles away,
and it might as well be a month or two before you get it. Rich, Dave, I'd like you both to weigh in on this. You know, when we're talking about the delivery of these services, and Russ, you said something about, you know, you want it to be at least seemingly seamless. As a let's call a healthcare provider like Roper, like Lawrence County, let's call them an agent. When you are an agent and you're not principal, maybe you do own the doc's practices, maybe you don't, but whatever you're trying to do is you're trying to act as an advocate for that patient, I would guess. You know, at least knowing you, Rich, I know you're that way. So how, when you have implied authority, but you don't have final authority over not just the delivery, but the way it's delivered, how do you as a hospital make sure that this is a seamless transaction, that this really does end up being a good experience, good outcome or bad outcome?
I think you have to develop a good clinical integration model. As the paramount.
And tell me what
clinical
that means,
integration is the having a seamless flow of the care of a patient, from a primary care outpatient to an inpatient.
So a back
to a
office process, if you will, within a hospital.
Have that be seamless, so that, as Russ said, the information is shared across all those avenues. And I believe that you're only going to get to that when providers begin to partner and work together. Because right now what we do is we all act in silos. And I don't mean it to sound that drastic, but we all do our own thing, as the doctor just said. We need to be coordinating our care processes, not just within the hospital or within the medical staff in the hospital, but across other hospitals and providers. I speak from the perspective of a small community hospital. I can't be everything to everybody. But if I have a relationship where the patient can go to get their heart cath or their heart surgery, because we can share information and we can have that clinical backup, I call it the deep bench clinically, okay? Then I think we'll be there. But we've been too many times acting in silos. We want to be the community that has it all. We want to do everything, and we just can't afford that anymore.
So, David, do you have to use your powers of persuasion, or is there some other incentives that you can do to get all of your service providers to act more like a team?
Well, communication is absolutely the key to that, of course. And I think if I could go back to your point earlier about the outcomes, if I'm a business owner or business employer watching this show, or all of us are consumers of healthcare, I think the thing that's going to be the most important to me as a consumer is is what is that outcome? I mean, am I getting the best treatment at the right time in the right setting? And as a purchaser, if I'm buying insurance for my employees, am I getting value for that? And value is something we talk a lot about at Roper St. Francis Healthcare, and that's basically the cost divided by the outcome. And you have to have both of those. You want to make sure you're getting excellent results, you're getting it for a reasonable price. And I know that all the health systems that I'm familiar with around North and South Carolina are focusing on doing just that, focusing on their outcomes. Even Blue Cross and other health plans are coming to us, and they're putting a part of our payment at risk based on having these outcomes, and this is becoming much more transparent. In the past, it would be very difficult to find out how a specific doctor performed in a certain operation or a hospital with certain outcomes, but this, and I think it's a healthy thing as a consumer and as a large employer, because we're buying insurance for our employees, that we are being able to see who's doing what kind of services and what the value we're getting for the payment we're making.
Mm-hmm. Let me bring it back to the personal thing, the personal relationship that was brought up earlier. Russ, how much? You know, it's a hot issue right now, and people like the sound of it. They like to have more control about their healthcare choices, clearly. But I guess how much, let's start with this question. How much do people really want to, instead of, Rich, I think you said something about people just want to be healthy, and they want someone else basically to help them do it or do it for them. How much of a personal responsibility do people need to take, are taking now when it comes to their health care? In other words, let's just make sure we stay well and we don't even end up in the system.
Sure. Well, I would say, again, like our country, there's a lot of diversity in that answer. We have people in this country who are very health conscious, and I would say those individuals are probably at the low end of what it costs us to take care of them. We have people in this country who do not take very good care of themselves, and we have some healthcare crises of the likes of which we've never seen before. I heard at one point in time that our children may be the first generation of children to have a life expectancy less than their parents, and obviously that's primarily related to the child obesity crisis. So, you know, if you look at obesity across the country, where it's gotten today, you know, we're going to absolutely increase our costs as a result of that through diabetes and other heart-related conditions.
Mm-hmm. How does the regulatory uncertainty play into someone taking control of their own of the wellness program, Sam?
Well, in my practice, there's certain things that I go over a patient with that will make them live longer. And, you know, it's activity, exercise, smoking, control their blood pressure, cholesterol, and their weight. And it sounds easy, but for people to do that, it's very hard. Smoking is one of the most addictive things and hardest things for people to stop. And it's one of the biggest burdens on health care in the world. I read something recently, and I do scare my patients a little also, because it's that people that are diabetic usually die 8 years younger than they should. People that smoke die 10 years younger than they should, and it's not a healthy life.
But they know this. Don't they know this?
They know this, and it's hard. But employers, we talked about employers, they can be very helpful in this too. And we talked about the carrot or the
the stick or
the carrot. And I don't like that so much, but they need to be educated, and the employers need to offer means for them to get healthier in the workplace. You see every day the people that have gyms in their workplace, and incentivize them to be healthy and stop smoking, and even to the point that insurance companies or the employers are going to charge them more if they smoke or if they're overweight or they don't take care of themselves. And so sometimes you have to make them realize it's on them to help themselves, and it's just the nature of some people that it's hard for them to quit smoking, hard for them to exercise.
What are the utilization rates of people that do take advantage of wellness programs?
I can tell you that specifically for our hospital, and I agree with what's been said. We're hospitals, and so we need to take the lead. But you brought up before is a huge social issue, and we can't solve the social issues of the entire country, as Russ pointed out. So I think as a hospital or healthcare facility, we can set the stage, and we have things like that. We have incentivized our employees. I don't like the carrot stick approach either. I think I'll call mine a soft stick. That if we have employees who have an annual health assessment, and then they get graded on that health assessment, and that health assessment can be from 1 to 5. 1, if you are not doing what you should be doing, you pay the highest possible premium. If you're a 5, then you get a huge discount on your premium that you're paying as an employee. And we've done this now for a year, and we've tracked the data. And first of all, our numbers have gone from an average of 2.8 to 3.3 in 1 year. So people are improving their health status. Then when we look at our data from our usage of the services and medications and diagnoses, we see our costs have gone down. Now, not significantly, not what I would expect, but I believe it is working. So the next step for us is we bring that now from the employee to the employee's family, and that begins to spread out into the community. So it's all about
in hopes that you're trying to influence the employee through the family, or trying to provide the service to the family.
We want to do both. We want to be able to provide the service to the family, because the family, if the employee has insurance through us, then their family is part of that cost. But the point is, we want to make sure, as David said earlier, population health management is critical. And that's our problem right now. We're trying to shift from this pay for an event or for a service to managing the health of a population.
We have about 3 minutes left, and this always flies by. So I want to get to this great unknown about the Patient Protection Act that looks like will end up at the Supreme Court, whether there's a constitutionality to it or not. David, how do you see what will ever happen here in front of the Supreme Court? What would you expect let's call it Obamacare? What will happen to Obamacare in your mind?
Well, the issue is this individual mandate requiring everybody in America to have insurance or pay sort of penalty. And the reason frankly, is that if you don't require the entire population to be insured, they will wait until they become ill to become insured. Therefore, the cost of insurance is going to be outrageous. And it's by spreading that risk among all the population that we're able to have an affordable product for the consumers. I think eventually, whether the Patient Protection Affordable Care Act is passed or not, I think there will be dramatic changes, because the system we're in today, as we've talked about earlier, we have the greatest healthcare system in the world, but it's way too expensive, and the cost is just not sustainable. We're going to have to find some better way of being able to address those who are uninsured and be able to make sure that they're getting this preventive care that we've been talking about, to make sure that they keep out of the emergency rooms and keep out of the intensive care units.
Russ, how does a system like Carolina's healthcare system, clearly large, clearly lots of leverage with not just healthcare providers, but just in general in the industry in the Carolinas, how do you model what it might look like given A, with the Affordable Health Care Act, or B, or maybe C? How do you guys model that?
Well, we're looking at it from the standpoint of what would the additional demands be on our system. And clearly in North Carolina alone, you're looking at 4 million people who would get additional coverage. And I think that would be Medicaid coverage, and then possibly 4 million more who would get additional commercial insurance coverage that would be heavily funded by the federal government. Those individuals, based upon the one state that's done this already, which is Massachusetts, would require significant additional primary care and emergency room options.
I wish I had more time for you to give an answer to that. We're out of time, but thank you. David, I want to thank you for joining us, and our salute to Santee Cooper, Lonnie Carter, and of course, David, you for making the trek all the way from Charleston to Moncks Corner, especially in that traffic. We know how that is. Sam, good to have you on the program. Nice to see you. Thank you. Rich, nice to see you again. Russ, nice to see you again.
Thank you. Have a great day.
For all of us, we certainly hope you stay healthy and have a good weekend. Good night.
Thank you.
Major funding for Carolina Business Review was provided by the Duke Endowment, a private foundation in Charlotte, enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina, who's responsible for rising healthcare costs. Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health is a not-for-profit group of hospitals and medical clinics caring for surrounding communities. Their nurses, physicians, and staff are nationally recognized for their remarkable devotion to patient care. And by Sonoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries. And by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.com.